Welcome back, everyone, to another Rafael Medina subspecialty VMR. Today we have a neurology case and a neurology team discussing today, which is very, very exciting. I'll just introduce myself. I'm Vale. I'm one of the team members joining from Lima, Peru. Happy New Year's, everyone. Applying for neurology match this year. And I'll pass the mic to our star guest discussant today, Dr. Shi, who is a regular already, but we're really happy to have you back.
Thank you so much, Vale. I'm Helen Shi. I'm one of the neurohospitalists at Emory University Hospital in Atlanta, Georgia. Pretty happy to be back and Happy New Year, everyone.
Amazing. And now I'm going to introduce our team that makes everything possible behind the scenes, starting with, oh, well, starting with our case presenter, Sair. If you could maybe introduce yourself and tell us maybe a little bit of fun fact about you.
Um, Hi, everybody. My name is Sair. I'm currently working as a research fellow at Mayo Clinic in Rochester, Minnesota. Our lab is a cardiovascular lab, and our studies are mostly related between hypertrophic obstructive cardiomyopathy and obstructive sleep apnea. The fun fact about me is that I like to fuse dishes. Like I recently tried pizza fries, in which I fuse chicken spices with some potatoes, and it turned out to be a delicious dish. That's it.
Love it. Very experimental.
Yeah.
Amazing.
Okay. Yeah.
Thank you, Sair, for being with us today, and we are looking forward to your case. And now I'll pass the mic to our team behind the scenes, Sarah and Zimi, who are doing scribing and teaching points.
Hey, I'm Sarah. I am a med student at Emory University applying into neurology this cycle and really happy to be here this morning. Pass it to Simi.
Hello, everyone. Thank you so much, Wale and Sarah, for arranging the session, and very happy to have Dr. Shi with us and excited for Sair's presentation. Just looking forward to the session.
Brilliant. Okay, so I think we are set to go. Whenever you want Sarah to put the whiteboard, and Sayer will just start with your first aliquot. Okay, Sayer, take it away.
Yeah, thank you. So, we have a 55-year-old male patient that presented to us with dizziness for the last couple of days. So, this is the amount of information that I'm going to provide for the aliquot number one. Yeah.
I love this so much. Dr. Shi, I'm just going to share my thoughts before you jump in, complementing with your star discussion. This is so funny because this morning I was reading, yesterday and this morning I was reading about dizziness, so it's perfect for me. I think on CP Solvers we have talked about Dr. Newman Tucker's paper on the titrate approach to dizziness, which I really, really love, which is basically like talking about, the time onset and the triggers framework to define dizziness on four syndromes, right? So we can talk about like acute dizziness, which is continuous, or acute or like chronic on acute episodic dizziness, right? And then beyond, within those two big categories, we can separate them if they are triggered by something, for example, position, which is very common, or if they are just triggered by anything. And this is something that I would be looking for to kind of stratify the syndrome. We are seeing that the time course may be acute, like a couple of days. However, it's a little outside what I will probably classify as a hyperacute, maybe like vascular etiology type of dizziness that would maybe be very worried about, posterior fossa stroke, for example. However, if it's continuous, it would be something that I would be interested. So I would not go beyond that. I would just be very interested to say if this is a syndrome that is um, acute continuous or acute episodic, and if there are any triggers like position, like sneezing, coughing, like loud noises, like if there are any also exposures that may have triggered this dizziness, for example, medications, trauma, and go from there. What are your thoughts, Dr. G?
Yes, I love the framework that you are bringing up. I think that it's exactly the case of sorting out, is this a syndrome that is acute or chronic? And then is it continuous or episodic? That can help us sort out if something by history sounds to be more of a central etiology of vertigo or a peripheral etiology of vertigo, which is really our most important role. The additional features that I like to hear about, which I think we'll certainly hear more about in the history, is if the like what Vale was saying, for like what are the triggers, what was the patient doing when the symptoms happened, and when they're describing this dizziness, if they can use other words to describe, like is it a sense of is it vertigo, which by definition is a false sense of motion. So either the patient themselves feel like they're moving, spinning, there's rotation, or they feel that the environment is moving, spinning. Sometimes, so that would be, concerning for this, vertigo, which then we characterize into does it seem like more of a central cause of vertigo or peripheral cause of vertigo? People can sometimes also say that they're dizzy, but what they really mean is that they're lightheaded or that they, feel that there's such a broad differential to that kind of like lightheadedness type of description. It could be cardiac in nature, it could be hypoxia, it could be a metabolic derangement, could be medication related. There's so many other things, dehydration, being pre-syncopal. And so trying to tease out if we are talking about somebody having vertigo or somebody having that other category of all the things that could be causing lightheadedness. But let's hear a little bit more about the history, and then we can discuss more about how we think about vertigo versus lightheadedness.
Hey, we can continue with your second aliquot, I think.
Okay. Great thoughts. Really love them. So the next aliquot is, as he mentioned before, he's a 55-year-old male who was referred to the ER complaining of new onset weakness, dizziness, especially with standing and walking, vertigo and slurred speech for the last couple of days. There was no history of headache, abdominal pain, fever, recent illness, medication change, nausea, vomiting, double vision, photophobia, any urinary complaint or diarrhea, no chest pain, palpitations, syncope or pre-syncope. And yeah, that's it for the second aliquot. Yeah.
Yeah, so I love how your presentation, I think, really outlines what you're thinking about, the fact that you kind of put in your review of systems, ruling out fever, recent illness, any medication change, and any signs of possibly like a migraine, right? That could also trigger acute dizziness, like you ruled out photophobia and nausea, which I think those are great things to rule out. Yeah, so I think this is way more not so benign as probably we first thought it could be. We have some red flags here accompanying the dizziness, the new onset weakness that I would like to characterize more like, is it motor weakness or is it just like a generalized fatigue or asthenia that the patient may have? And then we have this not trigger, but like a predisposition of the dizziness that is worse when standing and walking. I think the component of walking is quite interesting because that for me suggests a little bit of an exertion component, maybe. And that, as Dr. Shi would probably make me a little bit worried about that hard. But then also, I think when standing and with walking, I also think about things that may, like, I don't know. Please correct me if I'm wrong, Dr. Shi, but at first I was like, could this be like a CSF or like hypotension, for example, that is worse when you are standing up or something like that? That I'm not sure how to make it in the brain exactly, but beyond, this may be like an exertional thing that's worse with the heart. Do you want to say something?
Oh, me? No. Keep going. I'm agreeing with you.
Okay. And then we have the slurred speech as well, which I think is really interesting. for me, all of these together, like the dizziness, weakness, and slurred speech, which at this point I'm leaning more for it to be like a disorder type picture rather than a aphasia type picture. I'm wondering if the brainstem may be compromised in this patient. And I'm for sure worried about a central process rather than a peripheral one. So what could lead to like acute onset brainstem syndrome type picture? For sure, like we would be thinking about an infection, an inflammatory process, um, a mass that may have grown so much that is now presenting as symptoms that could also happen, or a mass that has grown so much that is it goes beyond their vascular irrigation and can present like an ischemia type picture as well. So yeah, I'm very concerned about a central process, and I will be looking forward to characterizing better on my exam this dizziness with the HINTS exam, the new onset weakness, and to see if there's like true dysarthria. And I would love to hear your thoughts, Dr. Shi.
Yes, I absolutely agree that there are red flags in this patient with dizziness. We also hear that this patient has vertigo. I'm assuming that the patient has described to you that they are feeling a false sense of motion, that they themselves are spinning or the environment is spinning. And what we're given in this HPI, it sounds like or maybe I can clarify with Sayer, does from the onset of the vertigo, once it has started, has it at any point totally gone away, or is it like, I'm kind of imagining maybe there's like kind of a certain amount of vertigo that the patient is feeling those symptoms, and then with standing and walking it gets worse, but then when the patient is I'm guessing like sitting or supine or not moving, maybe it gets better but doesn't totally go away. Can you tell us if it totally goes away or not at any point?
Uh, in this patient, the symptoms do persist even the patient is lying down or sitting, and they are present, as I mentioned before, while he was walking or standing.
Okay. Thank you. That's very helpful. And so what I'm asking for, which is what Vale initially, like very initially brought up, is this patient having continuous dizziness or is it episodic? And what we're hearing, to me, I would characterize as somebody having constant dizziness, like constant and persistent dizziness with positionality that provokes worsening. When that in combination with the this weakness that the patient is feeling, this slurred speech, it definitely is making me think of more of a central etiology, as Vale is saying. Typically, when people have central causes of vertigo, so things that are structural in the brainstem or posterior fossa, typically that vertigo is usually constant. When somebody is having a more peripheral vertigo, usually it is more episodic. The additional features of this patient having worsening with standing and walking does make me think about, could this patient have some amount of truncal ataxia? They're reporting that they're feeling worse. I'm wondering if they are noticing that they're more unsteady or having that inability, their vertigo gets provoked, or that they're more unsteady when they're in an upright position. And so I'm definitely going to be looking for that on my exam. And then the weakness, I really want to know, is it focal? Is it generalized? Even if it is generalized, I would still be concerned about a central etiology, just because there's so much prime real estate in the brainstem. All of our cortical spinal tract fibers are going through the brainstem. And so somebody could have, true weakness in all four extremities. That is still a vascular etiology or, structural space occupying issue in the brainstem. And slurred speech is, there are so many possible localizations for slurred speech that definitely include cortical bulbar tract fibers that go through the brainstem. Also, could be sensory related if they're not feeling sensation as well on their tongue or their face. Could be coordination related, somebody having cerebellar dysarthria, or ataxic speech. So I'm very concerned that this patient may have a central cause of their vertigo.
Yeah, before you continue, Sayer, I just wanted to mention two teaching points that from my reading this morning, which I think, the walking component, it's quite odd, but if you have told us like these patients' dizziness is worse when standing, I think, someone on IED might be like, oh, is this orthostatic hypotension just, or is this like a positional type of vertigo, right? And I think from the titrate paper and from my understanding about dizziness and vertigo, we have to really like differentiate triggers versus like things that may worsen the vertigo, because usually with positional vertigo, which is benign, usually BPPV, this is triggered by position. But really any type of dizziness, any type of vertigo, even central, even something quite terrible like a stroke, can worsen with position and can worsen with standing. So we shouldn't, just because it's worse with the standing, we should not rule it out as benign, right? We should really make that differentiation. And the other thing is that sometimes we can have orthostatic like dizziness or vertigo that doesn't have an orthostatic response. So like the vitals do not complement the worsening of the dizziness when standing. And this may, be secondary to a Steele syndromes type when we have an stenosis of the carotid, and when we stand up, there's hyperperfusion to the brain, but it's not orthostatic purely. It's, something a little bit more complex than that. So to be on the lookout for those two caveats when we're seeing something that may look orthostatic. Yeah. Saya, we're looking forward to your next aliquot.
Yeah. Once again, a great discussion, amazing thoughts. So I will proceed with my next aliquot. So I will present a past medical history of the patient. He has a history of grand mal seizures. Grand mal seizures previous episode 3 years ago. Anxiety, chronic hyponatremia. Baseline sodium was 132. Antiphospholipid antibody syndrome. Adrenal insufficiency due to blood clot to adrenal artery. History of stroke. MI, DVT, hypothyroidism, gastroesophageal reflux disease, hypertension, essential tremors, Raynaud's disease, sleep apnea. As far as his medicine history is concerned, he was taking oxcarbamazepine, lamotrigine, escitalopram, clonazepam, warfarin, dexamethasone, fludrocortisone, levothyroxine, pantoprazole, losartan, metoprolol, verapamil, vitamin B12, ferrous sulfate, primidone, and he was on CPAP as well. Occupational history, accountant. Social sport history, lives with his spouse. Smoking, alcohol, drug abuse history, socially uses alcohol and medical marijuana. Yeah, that's it for the third aliquot.
Wow, this is a heavy aliquot. This is someone that, has a lot of past medical history, and I think for me it's quite tricky to um, see if this might be somewhat related. I think for me, the ones that jump out are the fact that he has some predisposition to, stroke, the history of APLS, the history of stroke, of other areas of thrombosis in the body. I think for sure make this a person that may be at risk of a posterior fossa stroke. Then the history of seizures is quite interesting. It will make me, I'm not sure. I would probably would like to know if it's what triggered the seizure, maybe something that's completely unrelated. I just put like a pin on that. And then we have the history of APLS plus Raynaud's, that for me I mean, Raynaud's is quite tricky because I immediately think, oh, could this be like a systemic um, vasculopathy type of picture that's happening and now it's targeting the brain, right? But I think Raynaud's it's way more common or like and also very misdiagnosed. So I would be very careful to jump on that hypothesis. And the reason why I'm also really biased because this morning I was also reading about how sometimes peripheral vertigo can present with like fall-like episodes, like we see in Meniere's disease, like fall attacks without loss of consciousness, and that can be part of like Cogan syndrome, that also presents with eye problems and systemic vasculopathy. But that's just my bias, you know. I'm just that's like probably completely unrelated. So yeah, I think for me, this past medical history jumps my alarms for a very high risk of stroke, and I will be after my exam, of course, we will be running for the CT and CTA. Pass it back to you, Dr. Shi.
Yes, I absolutely agree, Vale. I think that you and I and everybody in the audience, our first reaction is, wow, this is a really loaded past medical history and medication list that to me, this is not the average 55-year-old, like middle-aged man who comes with vertigo. This person has a lot of past medical history that puts them at risk for all sorts of things that I didn't initially have higher on the differential. I think Vale and I both agree that stroke is high on our differential right now, and he certainly has a lot of risk factors for stroke. All the things that Vale said, especially with his antiphospholipid antibody syndrome, his prior thrombosis in to the adrenal artery, also prior history of stroke. He's on warfarin. I do wonder if he's therapeutic with warfarin, which can also be a little tricky. Like he may not be like, we don't exactly know what his INR was at the time that his symptoms started. Like his symptoms didn't just start in the last 24 hours. So our current INR may not be reflective of him being maybe subtherapeutic earlier in the week, leading to a vascular event. Also with, as everybody knows, with people who take warfarin, there can oftentimes be more fluctuations in the therapeutic levels than somebody who's on like Eliquis or something, although warfarin is the standard of care for preventing thromboses in antiphospholipid antibody syndrome. Also, we are hearing that he also has a lot of additional vascular risk factors like sleep apnea, hypertension. It's interesting that he, with the adrenal insufficiency in combination with the hypertension, or anyways, with the adrenal insufficiency, I wonder like where, and his hypertension, I guess, like where his blood pressure lives. Does he get hypotensive at times? Like, does he have also, like, does he have like autonomic instability? I see that there's fludrocortisone on his medication list in addition to antihypertensives, as well as all these medications that have central acting processes. Oxcarbazepine, lamotrigine, escitalopram, clonazepam, these medications, and his primidone. All of these medications can also contribute to both, lightheadedness as well as true vertigo. Like how are people, like people can absolutely have a central appearing vertigo, and they can have exam features that there's cerebellar dysfunction. They can have nystagmus, they can have dysmetria, like ataxia, whether that's appendicular or axial ataxia. They can have slurred speech, vertigo, all from medications that are bathing the brainstem and cerebellum and, with toxic effects. Like if their oxcarbazepine level is elevated or their lamotrigine level is elevated, even clonazepam can do it. People, for example, who are chronic alcoholics, they can have all of those features just from their cerebellum and brainstem being bathed in alcohol in the past, and also develop cerebellar atrophy, which can also happen with sodium channel blocking medications like oxcarbazepine and partially lamotrigine. And so I think that his past medical history and his medications may play a role in his current presentation. And I think that our exam will be really important to tease out, are there physical findings, physical signs that lead us to localize to one specific area, or if it seems like more of a general process.
Really like the rich discussion. Can I continue for the next aliquot?
Yes, please.
Okay. So in this aliquot, the vitals of the patient is temperature 98.4, heart rate 54, blood pressure 131/86, saturation 96, and general physical examination is normal. Uh, Similarly, the examination of eyes, ear, nose, and throat is normal. Mucous membranes were moist. We couldn't able to find anything specifically concerning on the cardiovascular examination, pulmonary examination, abdominal examination. I mean to say that they all are within normal range. As far as the neurological examination is concerned, the patient was awake, alert, oriented to person, place, and time. Speech was normal, language was fluent with no aphasia, attention and concentration were normal. Cranial nerve examination was within normal range. Motor strength was 5/5 in all limbs. Sensory examination showed normal light, touch, pinprick, vibration, and proprioception. Patient coordination, including finger to nose test, rapid alternating movements, and heel to shin test was normal. Bilaterally without dysmetria, gait was not tested. Skin examination showed no skin rash, no edema.
Okay. Sayur, was there any reason why gait wasn't tested? Was the patient super unstable that they could not stand up or something like that?
Sorry, can you please repeat?
Yeah. Was there any reason why the gait was not tested, like the patient could not stand by themselves or something like that?
So as I mentioned in the presenting complaints that the patient has a sense of dizziness and vertigo, especially when walking. So that's why I specifically mentioned that point over here. And uh, regarding the initial labs, his hematology was done. That was within normal range. White blood cells normal, hemoglobin normal, platelets normal, MCV normal. As far as the chemistry is concerned, so his sodium was 125, potassium normal, chloride normal, bicarbonate normal, blood urea nitrogen normal, glucose normal, calcium, magnesium, AST, ALT, ALP, bilirubin, albumin, all were within normal range. There were no significant, like, I mean to say that his EKG was within, showed normal sinus rhythm. Yeah, that's it for the fourth aliquot.
Yes, I think this would be a good place to pause. I think that Vale and I are both wanting to know more about the neurological exam, and I absolutely agree with Vale's direct questioning of why was gait not tested. It's a very, it's a very important part of the neurological exam, especially in a patient who feels symptomatic when they're walking. There's so much that can be picked up. Are they having truncal ataxia? Are they having, can they walk like, tandem? Do they seem to have asymmetric weakness when they're walking? There's so much to see in the gait exam. And so I wish the gait exam were done. But Vale, I want to ask you, are there additional exam maneuvers or exam testing that you want to do on this patient?
Yeah, for sure. Yeah, I think, it has happened to me before that sometimes, I'm alone on the ED or something, and the patient is, I'm a kind of tiny person and cannot do the gait or assess the gait alone. So yeah, I think that's fair. I would love to do the HINS exam, and I think people may know the HINS exam. It stands for like um, the head maneuver, like the doll's eyes maneuver, then the nystagmus, and then the test of skew. So these three tests really help us, especially, well, only if the patient is, of course, like actively dizzy. Um, it even has a greater sensitivity relief than an MRI, especially on acute strokes of the posterior fossa, like before 48 hours, I believe, because sometimes when there are strokes that are very small, and especially in that area of the brain, they may take a while to show up. So how do we do the HINS exam? So the head maneuver that we do is basically asking the patient. Oh, sorry, Dr. Shi, do you want to say something?
Oh, it's HI, head impulse testing.
Yeah, I forgot the HI head, yeah, head impulse. Just thank you for that. Yeah, we just ask the patient to kind of see our or look into our nose, the examiner's nose, and keep their eyes there. And we just like rotate first, like very gently, their head, and asking them to keep them looking at our nose. And then we quite briskly turn to one side and see if, they can keep on looking on the nose, or if there's a corrective saccade. So like they lose the focus and then they correct with a saccade to the center. And what we are trying to test with this head impulse is basically like fixation, or like the possibility of like coordination of the eyes. So this, of course, relies on the afferent input of the vestibular nerve and the eighth nerve. And so it means when usually it's impaired unilaterally, that the vestibular system is impaired. So an abnormal head impulse would suggest a peripheral problem, versus a normal head impulse, meaning that it would mean that bilaterally both centers would have to be affected, because on the brainstem we have bilateral, um, centers for these reflex or impulse. And so usually when we have a central problem, the head impulse is normal. So it's one of those occasions when a normal test is alarming. And then we have the nystagmus, which nystagmus is only as good as the syndrome that is part of, because sometimes we can have, for example, BPVV, which is a benign type of vertigo that can have, depending on the location of the otolith that has dislodged in the system, we can have what may look like alarming nystagmus. We classically say vertical nystagmus is an alarming sign, but that can also be part of benign syndromes. So this is why the syndromic classification is very important. When we have an acute continuous vertigo, rotatory nystagmus, or like direction changing nystagmus, or a vertical nystagmus, this is when we should be very, very alarmed. And then of a central process. And then we have the test of skew, which is basically like covering the patient's eye, asking them to see or like stay fixated in our nose, and covering one eye and then the other and then the other. And we should, if this is positive or signs of a central process, we can see the pupil going up and then down and then up when we uncover. So if we uncover and we see the eye is a little bit up, that's a positive sign, and that's a sign that this may be a central process. And the HINS exam, which is, the collection of these three maneuvers, is positive or sign that we should do an MRI if only one of them is present. So yeah, this is what I would love to do, Dr. Shi. What are your thoughts? What else would you love to do?
The additional testing, well, so in a patient who's having constant dizziness, I absolutely agree. Doing the HINS testing is very important. And the HINS plus testing, adding on the plus part would be seeing if they have any hearing loss, which by history, like acute, with this syndrome having worsened hearing loss or any amount of hearing loss, And so testing for that would be typically I would take out my 256 hertz tuning fork and test Weber and Rene to see if there's sensory neural hearing loss. The other things that I would typically assess for are for the HENT exam, normally I do look in the ears to see if there's any vesicles or any lesions on the tympanic membrane or anything that's visible. Also, I would generally, I do test like going through cranial nerves, which I think maybe you said this, like making sure that the palate does elevate symmetrically. And usually I do test sensation with a pin because when people have sensory loss from a posterior uh, circulation stroke, for example, like a Wallenberg syndrome, they can have ipsilateral facial sensory loss to pinprick temperature and contralateral body loss of pinprick temperature. In the majority of patients that I see who, usually on exam have a more clear-cut Wallenberg syndrome, they have like ipsilateral ataxia and they're having like a lot of slurred speech, hoarse voice. Uh, they oftentimes don't feel that they have sensory symptoms, and it's only on exam when you're testing with a pinprick. And even with fine touch, sometimes they don't acknowledge or they don't feel that there's any sensory change. And so I definitely like to use pinprick testing. Also, when I'm concerned about somebody who might have a central process, I like to check for a Horner's. And so I take a really close look at their pupils to see just in ambient light if their pupil size is symmetric or do they have a miotic pupil. And sometimes that can be pretty subtle, like the meiosis can be subtle and also the ptosis can be pretty subtle. Anhidrosis would really be usually by history and but of the people who have a Horner syndrome, we would expect, anhidrosis would definitely be a feature that rules in like a first order a Horner syndrome. So something that, if somebody is having a Horner syndrome that features anhidrosis, you would definitely be concerned about something going on in their brainstem. Or going down to the like sympathetic chain. And yeah, I would say that those are the main exam features. Oh, the one other thing I would say is in somebody who, you know, uh, does have worsening with position, oftentimes I will still do a Dix-Hallpike. And I think that it can just give additional information if they, especially in somebody whose exam is otherwise very normal. From what I'm hearing of this neuro exam, the patient having this like new onset weakness and slurred speech, we're really not detecting any of it on exam. And so then I'm broadening, my differential to could this be, BPPV and this person's just kind of a, either very symptomatic from their BPPV where like, they say that their vertigo is constant, but really it's provoked by any amount of movement and it's very hard for any human to just be totally still all the time. And so somebody with BPPV could report that, oh, it's been constant ever since it started. I don't get any relief and it definitely worsens when I move my head, especially if they say something like, oftentimes I'll ask, like, is there anything that you could do right now to make your vertigo come on? Or, some position that you would really avoid doing. And sometimes people are very, very um, like self-aware and they're like, oh, if I, turn and lay down on my left side, it's definitely going to provoke it. That's something that I'm definitely going to do a Dix-Hallpike exam on. But if somebody's like, oh, like, if I move, it definitely gets worse, or if I stand or try to walk, it gets worse, I would still like to do a Dix-Hallpike on that patient. Overall, I'm a little underwhelmed by this neuro exam. Like I kind of expected us to find some abnormality for us to localize a lesion. And right now it seems like everything's like pretty normal based on this exam that you've done. I'm not sure if any of the additional exam maneuvers that Vale and I would like to do, if any of that would show something positive that leads us to something that could help us localize either in the brainstem or vestibular system, like central or peripheral, or maybe this is exactly not a process that specifically localizes.
Yeah, pristine discussion. So this is my last adequate. Um, the patient was shifted from the emergency room to the ICU, and his MRI was done. MRI brain was done that showed a 1 centimeter multiplied by 3.5 centimeter chronic infarct posteriorly in the right cerebellar hemisphere, a 4 millimeter chronic lacunar infarct posteriorly in the left centrum semiovale, and mild chronic microvascular ischemic gliosis in the supratentorial white matter. And his serum sodium was checked. As mentioned before, it was 125. His serum osmolality was 257 milliosmol per kilogram, and urine studies showed urine osmolality of 360 and urine sodium of 62, uric acid of 2.5. Can I mention about the diagnosis in here?
Not yet, or I have just a couple of questions. One is, so his sodium is definitely low. We didn't acknowledge that earlier. Low sodium can definitely cause, many of these symptoms. Is that the reason for going to the ICU, was for a sodium of 125? Or was there
Yeah,
another reason for ICU
yeah.
admission?
This was the reason. Yeah, 125 sodium.
Okay, great.
Yeah.
And maybe I will leave it to Vale or you or the audience to interpret the serum and urine osmols and the urine sodium. I haven't done that in a while. I'd have to pull up a chart. But certainly I know, what we're getting at is characterizing the hyponatremia, and without knowing what the interpretation of the osms are, this is a patient who's definitely at risk for SIADH, especially with the oxcarbazepine use. And even when you were talking about the past medical history earlier of him having chronic hyponatremia, seizures, chronic hyponatremia, in my mind, I'm wondering is this all just from taking oxcarbazepine or carbamazepine? Oxcarbazepine does have a higher risk for hyponatremia than carbamazepine. But I'm imagining it must be very effective for this patient, for their neurologist to keep them on the oxcarbazepine and monitoring that their sodium doesn't drop too low, although here the patient is with too low of a sodium. This altogether goes along with what we were saying earlier of medications or other substances that can bathe the brainstem and cerebellum in toxins or bad humors that can cause them to have all the symptoms of an actual cerebellar or brainstem process, just usually without specific focality. Okay, so that's what I wanted to say. Vale, do you have any thoughts or any interpretation of the MRI?
Yeah, I think I can tackle the hyponatremia. I for sure was seeing everyone on the chat talking about the sodium, and I was like, oh, I hope it's not the sodium, but it ended up being the sodium. And I think, yeah, with the hyponatremia, we usually start with the serum osm. So I appreciate Sayer's kind of putting the information, kind of step by step to help me remind myself that schema. So with the serum osmolarity, we are looking to see if this is true hyponatremia or there's something else that is, masking the a high osmolarity and lowering the serum sodium. And in this case, we do see a low serum osmolarity, so this is true hyponatremia. And then we pass to a urine osmolarity, in which case, we see if it's high or low, and in this case, it's greater than 100. So we can, think about reasons on the kidneys or that may be losing sodium or not. And for that, we look for the urine sodium. And in this case, it's high. So in this branch point, I think SIADH could leave. Another thing that I'm seeing on his past medical history that could present with this pattern of hyponatremia is hypothyroidism. So maybe it could be worth checking a TSH. But I'm not sure if with any other symptoms. But I mean, hypothyroidism is another one of those metabolic derangements that can present with a lot of neurological, very complex syndromes. So maybe worth it. And then, yeah, I totally agree. I think SIADH, also an adrenal insufficiency could also live in this pattern of hyponatremia. So we have like three hypotheses, or like three things that could be causing the hyponatremia and the presentation of this patient. And I think maybe checking for a cortisol level or like a serum 24-hour cortisol, and also the TSH, and then yeah, to see exactly what's the main culprit and correct accordingly, and see if the syndrome kind of resolves with that. That kind of would be my main course of action.
And I would add to that to also check levels of the oxcarbazepine and the lamotrigine.
Yeah.
And I'll also comment on the MRI brain, which we are seeing has a lot of chronic findings. Interesting that one of the chronic findings includes a chronic stroke in the right cerebellar hemisphere, which could, when it occurred, could have caused him to have vertigo, also could have caused him to have right appendicular ataxia, so right arm or right leg, dysmetria, dyscytokinesis. And, if this patient right now on your exam had shown us that he was having some right-sided dysmetria, dyscytokinesis, of course we'd be like, oh, like maybe he's having a new stroke, and then the MRI is done and it shows chronic stroke. We'd be like, oh, okay, well, this is probably recrudescence in the setting of hyponatremia. One could wonder, like, could he be recrudescing just the vertigo portion and not the appendicular ataxia? I think that's a possibility. It doesn't really matter at this point because treating the thing that is causing recrudescence is most important. Also on the MRI, there's chronic findings of chronic stroke in the left centrum semiovale. So the centrum semiovale is part of the corona radiata. So that is, where the cortical spinal tract fibers, so the motor fibers, are passing through and down, the frontal lobe and the white matter. And so that at some point could have caused him to have right hemibody weakness. It doesn't seem like he's having any of that symptom right now. And then mild chronic microvascular gliosis would be like the microvascular ischemic changes that we can see when people have hypertension, sleep apnea, diabetes, and fortunately for him, it's mild, and usually for everybody, it's asymptomatic. And so now you can tell us what the diagnosis is.
Great thoughts. So the diagnosis, as well, I was asking. So we did the test. The TSH cortisol levels were within the normal range, and as you mentioned, to check the level of oxcarbazepine, it was found out to be the case of the SIADH caused by oxcarbazepine, as you mentioned before. So we did. So what we did was the patient was managed by discontinuing IV fluid restricted to 1500 ml per day and initiated on a salt tablet of 1 gram. The neurologist changed his carbamazepine tablet to licosamide, and he was discharged. Yeah, that's the case. Yeah.
Wow, this is very humbling, I think.
Yeah.
Because for sure, this is very real life, I think, of, something that, I don't know, I think really highlighted my biases in this case, the fact that I was like jumping in straight to like an structural cause when we see a patient that has a lot of factors that may just be put on them on the edge of a discompensation of a baseline condition. I think a question that I remain having with this patient, and I would love your thoughts on this, Dr. Shi, is like, because his symptoms initially, I have a little bit of trouble like concluding if something is recrudescence versus something like being a TIA, for example. Having that confidence and saying, no, this is recrudescent, right? And not hunting for something that could be a TIA now, but could be another stroke in the future, right? I guess management-wise, this patient is already in anticoagulation. We don't have a lot to do, maybe more. But yeah, because I see some things that may be a little inconclusive in my mind. Like, for example, the blood pressure. If this patient had not had adrenal insufficiency, I would be like, oh, this is a normal blood pressure, but may this be a little higher for him, 130 over almost 90? And could that be a clue that this patient may be having a TIA versus just normal? I don't know. I guess I'm just having trouble. Or like, when do you feel confident saying, no, this is right recrudescence, or when should like stop the workup, looking for something more, I guess?
That's a great question. So I would say first, it's important to determine clinically, does it seem like the patient had a TIA or not? And so TIA, the current definition is that symptoms last less than 24 hours, and that it fits in a vascular pattern, and that imaging is negative. And so for me, like this particular patient, I'm really not thinking that this patient has had a TIA. The symptoms have lasted for more than 24 hours. The neurological exam shows us that there's no features that are clear cut for a vascular pattern. I mean, we were talking like, okay, well, maybe this patient just has, isolated central vertigo, which this patient does have does have central vertigo. It just happens to be in this case caused by the hyponatremia plus minus recrudescence because of the hyponatremia. But on exam, we're not seeing any additional features that make us very concerned for a specific vascular territory. And the MRI, has, for better or for worse, shows us a chronic lesion that could recrudesce with symptoms of vertigo, possibly. Would be much more convincing if he also had right-sided ataxia right now as part of like a whole recrudescence picture of vertigo plus right-sided ataxia due to the right cerebellar stroke, chronic right cerebellar stroke. But in this particular patient, I wouldn't be so concerned for a TIA in combination of the symptoms lasting more than 24 hours, symptoms persisting I'm assuming they persisted while he was getting the MRI. But, in another patient, like let's say, this happens all the time. Let's say there was a patient who comes because they had transient, family witness that this patient was like talking fine, everything was fine, and then had transient difficulty with fluent language, was not able to speak fluently, had a lot of word finding difficulty. They had a right facial droop, their right arm fell, and then symptoms were resolved within 30 minutes before they came to the ED. That by our hearing just the history, even though their exam is totally normal, would be like, oh, wow, that's like pretty concerning for transient left MCA syndrome. And let's say that the patient, they were back to baseline, we would be like, oh, wow, that really sounds like a TIA. And they, clinically have never had that symptom before. And then we do an MRI, and if the MRI is normal, we'd be like, oh, well, this person had a TIA. We got to like do our whole like TIA stroke evaluation because we don't want them having another syndrome again in the future, another TIA or stroke in the future. But let's say this patient did have a chronic left MCA stroke that was never visualized, or that the patient never knew of before. In that patient, we would be like, oh, well, maybe it was a new TIA, like maybe it was a new TIA, like a new vascular event that was a TIA, even though they have an old stroke before, or maybe they recrudesced their old stroke. Well, let's see, like, do they have any labs that show them that they, have a reason to recrudesce, and then, in a patient that has a chronic stroke, they still deserve a stroke workup, or, like, we still want to know, like, why they had that in the first place. So, I don't think, to me, I'm not so concerned about, like, when do we feel confident that something is recrudescence. What I really want to know is, do I think that they had symptoms referable to a vascular territory, even if it was transient? And then, do they have imaging findings that show that they are either having a stroke now or had a stroke in the future? And what can we do to prevent them from having strokes in the future? In this patient, I do not feel like this patient had a TIA, and everything fits with either just hyponatremia causing all of the symptoms, or hyponatremia plus the cerebellar, like chronic cerebellar stroke causing some recrudescence. And then at the end of the day, it's like, why is the patient hyponatremic? And is it from something, for me as a neurologist, I'd be like, do I have a contribution for the workup of this hyponatremia? Well, I really care about the oxcarbazepine and the lamotrigine levels, because that's something that I'm in charge of, that I need to adjust if needed. And so, lo and behold, it's SIADH from elevated oxcarbazepine, and they definitely had the appropriate management of switching to lacosamide, which is Vimpat, and maybe should have done that earlier, because he was already known to have hyponatremia on oxcarbazepine. Very great case.
Thank you,
Yeah,
Dr. Sorry, Sayar, go
thank
ahead.
you. Thank you so much, Dr. Shi and Vale. I learned a lot from this case. Yeah. Looking forward to present more cases in the future. Yeah.
Great
Yeah,
job, everybody. Thank you all so much.
Yeah. Thank you. Bye.
No, thank you both. This was amazing. I'll just now pass the mic to Zimi for some teaching points.
Wonderful discussion, and after such rich teaching, I have nothing to add. And just I want to thank Valley and Sarah for arranging this session. And Sarah also helped Sarah prepare the case. So thank you, Sarah and Sarah, for presenting the case. And I will just share my favorite teaching point, that when we have vertigo, when it is central, it is more persistent. When it is peripheral, it is usually episodic. And I would like to just share, just as Dr. Shi said, that we have to look for medications if they are contributing, because carbamazepine and oxcarbazepine can also cause cerebellar atrophy, and here it was causing syndrome of inappropriate age. And that's for the teaching points. And thank you, everyone, for a wonderful session.
Thank you, everyone that made this possible, and we'll see you on the next one. Thank you, Dr. Shi. It was a blast to have you.
Bye.
Thank you, Sayir.
Bye. Thank you.
Bye.